My name is Robert Gniadecki. I'm a dermatologist and professor of dermatology, and I'm trained in Denmark, in Copenhagen. I work in Europe, in Denmark for many years, 20 years, more than that. And then in 2015, I moved to Canada, to University of Alberta, when I'm a professor as well and practice clinical dermatology. And my main interest is autoimmunity and psoriasis. It's the first part of my research, and the second part is malignancy of the skin, especially the cutaneous T-cell lymphoma, which is, I guess, irrelevant for the topic of today. Okay, so my interest in psoriasis is not only the skin manifestations, which is the usual point of interest for many dermatologists, but how the psoriasis affects our overall health, especially overall survival. This is not a new idea that psoriasis is an autoimmune inflammatory disease that not only affects the skin but also the entire human body. And back in the 70s, it was observed that patients with psoriasis have a higher risk of other diseases, especially metabolic diseases and cardiovascular comorbidities like a stroke, brain vascular catastrophic conditions, hypertension, hypercholesterolemia, so the whole constellation of metabolic risk factors for cardiovascular diseases. And for many years, it was not very clear whether psoriasis is the cause of this, or is the metabolic dysfunction one of the causes of psoriasis. So this was a topic of my research for a number of years, starting in Denmark. So back then in early 2000s, we were using the Scandinavian databases to analyze the overall survival of patients who are on the biologic treatment and who are on like more old-fashioned psoriasis treatments. And we found out that the patients who have psoriasis have a shorter survival than patients who are not the patient, like the healthy controls. So we matched the psoriasis patient to healthy control people and found out psoriasis patients die 2 to 3 years sooner than the healthy patients. Again, this was not clear whether this is the cause of this is psoriasis or whether the cause of this is the cardiovascular comorbidity. So when I came to Canada, I had the opportunity to look into the Canadian databases, which in many ways for this particular project were superior, because in those databases we were able to also retrieve all the treatments and all the other diagnoses that were given to the patients. This was not possible in Scandinavian databases because only the diagnoses given in the hospital setting were recorded in those, and so we didn't have access to all the other diagnoses. So we set up the study this way that we retrieved all the psoriasis patients in our Canadian population in the province of Alberta, and the province of Alberta is about 4.4 million people. And we could find from the last 8 years a cohort of new diagnosed psoriasis patients of about 18,000. And we met those patients to 55,000 of the control subjects, which were not totally healthy. So those were the patients who also had contact with healthcare, but they did not have psoriasis. And to compensate for other comorbidities, we stratified the patients by something called Charles Comorbidity Index, which is like a number, an index which reflects the patient's general health. So in each layer of the Charles Comorbidity Index layer, we had patients with psoriasis, and we have 3 matched controls to each patient. And even though we matched the patient for all the comorbidities, we found out that the patients with psoriasis have a shorter overall survival by about 2 years, which is a considerable amount of time. So the patients with psoriasis, the average age of death was about 72 years, and for our matched subject was 74.4 years. So it's 2.5 4 years shorter survival. So So then we looked, why do the patients die? And we do not have always the cause of death. Cause of death is a very difficult topic in medicine, so we don't always know why the patients die, but we could confirm that the patients of psoriasis, those they have cardiovascular disease, it contributes to the risk of death. But we also found two other important factors. One is the hepatic disease, so liver disease, and this was the strongest contributor to the overall risk of death. And the other one is the psychiatric comorbidity. So mostly depression, bipolar disorder, suicidal ideation. And this was also a major contributor to premature death, independent on the liver injury and independent on the cardiovascular death. And this was an interesting finding because why should the bipolar disease shorten patients' survival? So we thought maybe some of this is the effect of inflammation and effect of psoriasis, but some of this could also be effect of the treatments that patients get for psoriasis and for those associated disorders. So what we did, we tried to analyze the impact of different treatments. So we started with the impact of psoriasis medications, and here we had a chance to compare the biologic medications versus methotrexate. So they were independent two groups, only treated with methotrexate or treated with the biologics, and patients who did not get any systemic treatment. So they were kept on topical treatments. And somewhat to our surprise, we found out that the patients of biologics have a longer survival. So the patients treated for biologic, if we compensate for all other risk factors, so the comorbidities, the general health, they have generally a better survival. The survival doesn't come back to the normal value, but it's vastly improved. This was not only related to the psoriasis treatment because patients who were on methotrexate and have equally good outcomes, their survival was not changed comparing to general population of psoriasis. And then patients who were on topicals only had the worst survival. So this was the first conclusion, which was very positive because it meant that what we do in dermatology, treating patients with those anti-inflammatory biologics, we actually do something good. We increase the overall survival, or at least what we do is associated with longer survival. And then we looked on the treatments or at the treatments that we use to treat other diseases like the psychiatric comorbidities, liver disease, and so on and so on. And here the results were a bit counterintuitive because we found out that many of those treatments, even if you compensate for the severity of the disease and the type of the disease, they are actually associated with increased mortality. And this was especially true for corticosteroids that I guess were given for patients with psoriatic arthritis and hypnotic and sedatives. So those three classes of medicine were associated actually with a slightly shorter survival. So what is the conclusion of this study in practical terms? So it gives us reassurance that treating patients with biologics is a good thing. We are not impairing their health. We're not impairing their survival. On the other hand, we should be careful when you have the patient, should pay attention what else they are getting, what they are treating with, because many of those other medications can actually be deleterious to the patients. So maybe you should engage in a better discussion of family doctors with the internists who treat the other diseases to really be sure that what the patients are treated with is necessary for them, and maybe to avoid polypharmacy in the patients with psoriasis because this is not to the advantage of the patients. So this is like in brief notes the summary of my presentations at AAD this year. Yeah, so thank you for giving me the opportunity to talk about the future. So I will tell you what is the biggest problem with methodology of the research. So we're looking at the retrospective databases. This is not a prospective study where you can randomize the patients to different treatments. So the data are very noisy. and subject to bias. Also, the fact that the patients get different medication different times introduces a lot of noise to the statistical analysis. So not always possible actually to dissect the effect of the treatment. So we clearly need new methods how we are looking at the outcomes of our patients. And the method that I find very promising is using AI, so artificial intelligence modeling, to model the long-term outcomes. And we have already done some preliminary studies using something called SHAP analysis, which is AI-based tool to dissect the effect of different influences on the outcomes. And it is complicated. It needs a lot of computer power. But the positive conclusions is that what we have achieved actually confirms the data or confirms the results that we gain from the study. And probably in the future, we can fine-tune this method to look at the bigger populations and the outcome. So this is my kind of plan for the future in this field, to use more advanced statistical analysis to be able to dissect this very noisy data set and be able to produce data which will be just another method to confirm or to refute what we have found up till now with more classical approaches to statistics.